Mixed pelvic organ prolapse, multi-compartment robotic approach. We present the case of a 63-year-old female with no notable past medical or surgical history and an obstetric history of 2 non-instrumented vaginal deliveries. The patient presented with a long-standing history of rectal prolapse occurring primarily post defecation, accompanied by urinary urgency and chronic constipation. Upon clinical examination, a grade 3 cystocele and rectocele were identified. As demonstrated in the accompanying video, both the bladder and rectum protruded beyond the vaginal introitus during Valsalva maneuver. The patient also exhibited a complete rectal prolapse. Preoperative assessment included an rectal manometry, which revealed normal resting pressure and contractility but abnormal expulsion dynamics. Pelvic floor MRI with dynamic assessment was then performed, revealing a severe cystocele, an anterior rectocele, and a complete rectal invagination. These findings were consistent with advanced pelvic floor dysfunction and significant anatomical laxity. Given the multi-compartment nature of the prolapse, the patient was scheduled for a robotic-assisted ventral colporectosacropexy using an inverted Y-shaped titanium mesh. Upon entering the peritoneal cavity, meticulous exposure of the surgical field was critical to ensure optimal visualization and access. The sigmoid colon was carefully suspended to the left paracolonic gutter, which provided an ideal pathway to the sacral promontory. This positioning also allowed for the direct visualization of the vaginal vault and the Douglas pouch. Next, the anterior pelvic peritoneum was opened using monopolar scissors. Once the peritoneum was incised, dissection of the rectal vaginal septum was initiated medially, at the point of the insertion of uterosacral ligaments at the level of the cervix and the vagina. The dissection was extended distally along the posterior vaginal wall, continuing until the level of the levator ani muscle. Following this, dissection of the lateral pelvic peritoneum was performed, extending towards the sacral promontory located at the L5-S1 level, inferior to the bifurcation of the aorta. The peritoneum covering the sacral promontory was carefully incised to access the underlying fibroadipose tissue, which was dissected with particular caution to avoid damage to the right hypogastric nerve. At this stage, a subtotal hysterectomy was performed. Our surgical team favors this approach, as preserving the cervix provided a more stable anchoring point for the mesh, thus minimizing the risk of the mesh extrusion and infection. Furthermore, the patient expressed her agreement with the decision to proceed with the hysterectomy. Following the hysterectomy, a flat malleable retractor was used to maintain tension of the vagina, facilitating further dissection of the vesicovaginal plane. This step allowed for the exposure of the anterior vaginal wall with sufficient lateral extension, ensuring the mesh could be properly positioned and expanded. Once the dissection was completed, the anterior defect was carefully measured, and a polypropylene titanized mesh was tailored to fit the anterior cervix and vagina. The mesh was then positioned and secured using loose non-absorbable sutures, ensuring the mesh was stable but not overly tensioned. The posterior compartment defect was then similarly measured. A second titanized mesh was tailored for the posterior compartment, with a long tail extending to cover the open lateral peritoneum up to the sacral promontory. Before final mesh fixation, tissue adhesive was applied to help prevent mesh displacement during suturing and to promote integration with surrounding tissues. Once the meshes were fixed, they were adjusted and tensioned. The anterior mesh was secured first, followed by the posterior mesh, which was fixed in an inverted Y-shape using the same non-absorbable sutures. Care was taken to ensure that the longest tail of the posterior mesh was securely attached to the sacral promontory, with special attention given to the avoidance of neurovascular structures in the surrounding area. The final steps involved completing the dissection of the meshes to one another with additional sutures of the same non-absorbable material. Additional tissue adhesive was applied over the fixed meshes to ensure they remained stable and in place. Finally, the pelvic peritoneum was closed using Vart V-lock sutures, completing the procedure. The patient experienced an uneventful recovery and was discharged home on the third postoperative day, reporting no pain or discomfort. At the 5-month follow-up, the patient had no complaints of urinary urgency, chronic constipation, or rectal prolapse, which had previously been her primary concerns. A pelvic examination confirmed that the cystocele and rectocele were no longer present, and there was no evidence of rectal prolapse or any mesh complications. The robotic-assisted ventral colporector sacropexy using an inverted Y-shaped titanium mesh offers an effective approach for the anatomical repair of the multi-compartment pelvic organ prolapse. This technique allows for a single, minimally invasive procedure to address complex prolapse involving the bladder, rectum, and uterus. The robotic approach enhances precision and safety, leading to optimal surgical outcomes.